Most common sinus involved in allergic fungal rhinosinusitis. Options are maxillary, ethmoid, frontal, and sphenoid. Answer of this question is most common sinus is ethmoid, followed by maxillary, followed by frontal, and last sinus is sphenoid. This is the sequence of involvement in the fungal rhinosinusitis. Allergic fungal rhinosinusitis is a non-invasive fungal sinusitis resulting from an allergic or immunological response to the presence of extramucosal fungal IP in the sinuses. And most common fungus is Aspergillus fumigatus, followed by Bipolaris, Carvularia, and Alternaria are also common pathogens leading to allergic fungal rhinosinusitis. Prevalence of Afrs among the chronic rhinosinusitis cases is about 30%, while in fungal rhinosinusitis cases these are about 60%. So, most common fungal rhinosinusitis are allergic fungal rhinosinusitis. The typical AFRS patient are young immunocompetent patient and age is about 20 to 35 year of old. There is more common in male than the female. Ratio is about 2 is to 1. And it is found most commonly in the lower socioeconomic class. The underlying pathophysiology remains unknown and controversial. It is believed that an atopic host exposed to fungi results in antigenic stimulation by the Coombs type 1 and type 3 hypersensitivity reaction leading to T helper type 2 inflammatory response. Another theory is the immunological theory which proposed because of raised Ig level which stimulate the antigen antibody reaction and formation of IgE and IgG antibodies. But this also fails to explain the unilateral or asymmetrical nature of AFRS, as fungal secretion or fungi are present about 96% of the normal individual. So, how to define the immunological theory? Based on this, it fails to explain the pathogenesis of the fungal rhinosinusitis. Eosinophil related fungal rhinosinusitis. The controversies area are allergic fungal rhinosinusitis, eosinophilic fungal rhinosinusitis, and eosinophilic mucin rhinosinusitis. So these three topics are related with the allergic fungal rhinosinusitis. On the basis of result of fungal staining of the mucin and the presence or absence of fungal allergy, patients are categorized into four categories. Allergic fungal rhinosinusitis having positive for fungal allergy and positive fungal staining in mucin both, while allergic fungal rhinosinusitic like sinusitis having positive for fungal allergy and negative for fungal staining in the mucin, while eosinophilic fungal rhinosinusitis having positive fungal staining in mucin but negative for fungal allergy. And last, eosinophilic mucin rhinosinusitis having negative for fungal staining in mucin and negative for fungal allergy. These are only having high eosinophils. This is EMRS. In 2000, Ferguson performed a literature review and concluded that there is two different disease process. One is allergic, another is non-allergic fungal rhinosinusitis. The term eosinophilic mucin rhinosinusitis was used to describe non-allergic fungal sinusitis. These patients were felt to have histological features similar to allergic fungal rhinosinusitis but without the presence of fungus in the mucin. The underlying mechanism was believed to be systemic dysregulation of immunological control, resulting in upper and lower airway eosinophilia. By recognizing EMRS and AFRS, two separate entities with similar phenotypic endpoint. The treatment strategy for these patients can be formulated according to their pathogenesis. Antifungal agents and fungal immunotherapy should be theoretically benefit only in the AFRS cases, not in EMRS cases. Diagnostic criteria for AFRS. In 1994, Bent and Kuhn described diagnostic criteria for AFRS. These patients showing 11 important features. Major criteria are evidence of type 1 Ig mediated hypersensitivity, nasal polyposis, characteristic or double density or real track sign in CT finding, eosinophilic mucin and positive fungal smear. These are five major criteria. Minor criteria are six: asthma, unilateral predominance, radiographic bone erosion, fungal culture, charcot Leyden crystals, and serum eosinophilia. These are 11 symptoms, in which five feature are major symptoms and six feature are minor symptoms. In AFRS, all five major criteria should be present, while minor criteria are considered as a supporting feature. So, these criteria set the benchmark for diagnosis of AFRS for many years, with minor variation proposed over the years. If all five major criteria are not present, suppose 4, 3 criteria are present, major criteria are present, then it is called as atypical AFRS. Now, observation was seen that an elevated Ig level is not always present in all AFRS patients and may fluctuate within the normal range in the all disease stages. So new criteria were proposed, that is very effective criteria, that is called St. Paul Sinus Center diagnostic criteria for AFRS. These five major criteria are immunocompetent patient, presence of nasal polyposis, characteristic CT finding, presence of allergic mucin, and positive fungal culture or presence of fungal hyphae in fungal staining. These are St. Paul Sinus Center diagnostic criteria, that is more helpful, in which elevated Ig level has removed from the Bent and Kuhn criteria and immunocompetency added. So these are the five major criteria for diagnosis of AFRS. Clinical presentation. Although there are no pathognomic symptoms for AFRS, clinical suspicion should be high when one encountered a young patient with uni or bilateral nasal polyposis with thick, sticky yellow-green mucus discharge with characteristic finding on CT scan and who is responding with oral steroid. Often the symptoms are subtle and similar on the chronic sinusitis with the nasal polyposis. On nasal endoscopy, there is inspettated thick yellow or brown peanut butter like mucus seen among the polyps. So that may be a characteristic for AFRS patients. Investigations. Immunological test. Patients with AFRS have an elevated Ig level. In long-term follow-up of AFRS patient, the total Ig level were found between the 50 and 1000 international unit per ml. Average total Ig level was about 550 international unit per ml. Because of wide range of total serum Ig level in AFRS patient, it is not useful as a screening tool. But total serum Ig level may be useful in monitoring clinical activity in the management of AFRS patient. And skin prick test can be utilized to demonstrate fungal specific Ig level on diagnostic criteria for AFRS. Now CT scan. AFRS patients have typical feature that present on the CT scan, and CT without contrast is the imaging of choice in suspected patient of AFRS. The focal or diffuse area of hyperintensity seen on CT due to calcium and magnesium deposit in the necrotic debris of the fungus and allergic mucin. These seen as a double density sign or real track sign. On MRI, paranasal sinuses with intravenous gadolinium enhancement can be considered for AFRS in cases where diagnosis is uncertain or there is intracranial or intraorbital complications. The protein content and viscosity of the secretion will determine the signal intensity in MRI. In fungal infection, the consistency of the secretion usually results in low intensity signal in T1 weighted imaging as well as much lower intensity in the as a signal word in T2 weighted imaging. This is due to higher concentration of iron, magnesium and calcium deposit within the fungal secretions. So, CT scan showing heterogeneous signal intensity within the paranasal sinuses as a double density sign or real track sign. And there is expansion of paranasal sinuses and mostly there is unilateral or asymmetrical disease load on the CT scan. And sometimes there is bone erosion seen on the CT scan. So main sign is double density sign on the CT scan because of deposition of calcium and magnesium. And sometimes there is bilateral double density and bilateral disease with bone erosion also seen. On MRI, on T1 weighted imaging, there is central area of hypointensity with peripheral enhancement is seen in the AFRS cases. While in the T2 weighted imaging, there is central area of the hypointensity with signal void appearance in the area of the fungus, and there is single signal void in the T2 weighted MRI with peripheral enhancement. So hypointensity seen in both T1 and T2 weighted imaging in AFRS cases. Now histology. The hallmark of AFRS is the presence of allergic mucin, which is characteristically thick, tenacious, yellowish white in color, with highly viscous, seen as a peanut butter or excel grease appearance on the gross examination. On microscopy, allergic mucin consists of an eosinophilic mucin with necrotic eosinophil inflammatory cell, charcot-laden crystal that is part of the eosinophilic byproduct, and fungal hyphae are there. As fungal hyphae are infrequent and scattered within the allergic mucin, their detection is difficult unless specific stains such as silver stain, such as Grocots or Gomori methamine silver stain can be used. You can see in this picture there is charcot-laden crystals, scattered fungi, and there is allergic mucin in the microscopy. Fungal culture. Positive fungal culture provides supporting evidence in the diagnosis of AFRS. However, its absence does not exclude the diagnosis of AFRS. The presence of positive fungal culture in AFRS patient ranging from 50 to 100% depending on the culture method used. A positive fungal culture does not confirm the diagnosis of AFRS as well. The histological identification of allergic mucin is the most reliable marker for the diagnosis of AFRS. So culture is not important. What is important is the histological identification of allergic mucin is the most reliable marker for the diagnosis of AFRS. Management of AFRS. Once a diagnosis of AFRS has been established, patients are enrolled into a committed long-term management program which regular and long-term follow-up is critical by endoscopic and follow-up CT scan or MRI imaging. A combination of surgery with comprehensive post-operative medical regimen to keep the disease under control is utmost important. Surgical management. First line treatment in the management of AFRS is the endoscopic sinus surgery. Removal of the allergic mucin, fungal debris, eliminate the antigenic factor and disease atopy. Surgery also provide wide access for the surveillance, clinical debridement and application of the topical medication. So, first line management is the functional endoscopic sinus surgery for AFRS followed by topical or systemic medication. In some revision cases, it is necessary to use image guided surgery so that your plane of dissection is accurate or you will not damage any important structure during your revision endoscopic sinus surgery. Endoscopic staging of mucosal disease post surgery. Regular follow up and accurate documentation of the sinonasal mucosa of AFRS patient after surgery is critical to monitor disease status and response to medical treatment. Kupferberg et al. Devised a four-stage staging for the endoscopic follow-up in these patients post-surgery. Stage first is normal mucosa. Stage second is mucosal edema or allergic mucin on endoscopy. Stage 3 is polypoid edema or allergic mucin. And stage 4 is the sinus frank polyp or fungal debris is present. But this staging lack sensitivity, often resulting patient remaining in the same endoscopic despite having improved symptoms. And endoscopically there is no grading of staging. So new staging system is proposed in 2010, that is Philpott-Jaber system. The Philpott-Jaber system is much more sensitive and allows for better tracking of disease control postoperatively. In this system, there is sinus cavity right and left and allergic mucin present on both cavity. According to that, there is grading on the olfactory cleft right 0 to 9, frontal 0 to 9, ethmoid 0 to 9, maxillary area 0 to 9, and sphenoid. So in these five area, olfactory cleft, frontal, ethmoid, and maxillary, and sphenoid sinus, there is grading is 0 to 9, and that grading dictate the state of mucosa. 0 means no edema, 1 to 3 is mucosal edema, 4 to 6 polypoid edema, or 7 to 9 is frank polyp. So each side depending on mucin and mucosal disease, there are 50 score on each side and total score will be 100. So according to that you can grade and better grading for the post-operative monitoring of the endoscopic sinus surgery by this Philpott-Jaber system. Next line of management is the medical management. First is systemic corticosteroid. Oral steroids are useful in perioperative period of patient with AFRS. It given short period of systemic corticosteroid. Sometimes it's required 1 to 6 month post-operative regimen for treatment of AFRS in tapering doses. So it depends on the severity of the AFRS cases. Sometimes in recalcitrant cases, we required antifungal, topical or systemic therapy. Most commonly used drugs are oral itraconazole and fluconazole or voriconazole. Most commonly these drugs used in recalcitrant AFRS cases and proven there is less proof of this antifungal therapy for management of AFRS. Topical medication, mainly corticosteroid. Topical corticosteroid are used as a standard treatment for patients with AFRS. They are most effective in postoperative period when open sinus cavities and middle meatus allow access to the paranasal sinuses by the endoscopic sinus surgery. The benefit of topical over systemic steroid lies in the ability of topical steroid to achieve the highest drug concentration in the target tissue, means sinonasal mucosa, without undesirable side effect. Two positions commonly used in the topical nasal spray application. This is the Mirand position, that is better for the topical spray. Another position is the Makka position. In Makka position, the spray goes in all sinuses. So these two positions, Mirand position and Makka position, allow better topical medication or corticosteroid spray application in the nose. Next treatment is the immunotherapy. In most studies, there is clinical improvement is seen on the immunotherapy over a period of 3 to 5 years of immunotherapy. It may be sublingual or subcutaneous immunotherapy. Manuka honey. The Manuka species, that is Leptospermum scopoarium, that is honey from the New Zealand, is most therapeutically potent honey. It has been shown to be active against a broad spectrum gram-positive and gram-negative bacteria. The principal active ingredient responsible for antibacterial property in Manuka honey is the methyl glyoxal (MgO), and this present in Manuka honey in the concentration of 100-fold than the conventional honey, and this honey is very effective against the Staphylococcus aureus, which may be methicillin susceptible or resistance, and Pseudomonas. So, in biofilm cases of AFRS, that is very effective. So, you can apply topical Manuka honey application in cases of recalcitrant or resistant cases of AFRS. Future treatment strategy: anti-immunoglobulin IgE therapy, that is omalizumab or Xolair, is humanized monoclonal antibody IgE antibody that has been used as adjuvant treatment in severe atopic asthma, allergic rhinitis, and CRS with nasal polyposis. So, in some randomized double-blind studies, it is found that omalizumab therapy is also effective in cases of AFRS, and that improve the quality of life, airway symptoms about in 16 weeks of omalizumab treatment. So this can be given 1 monthly interval subcutaneously. So this therapy is also effective in some cases of AFRS.